Welcome to Health System CIO's interview with Roberta Schwartz, EVP and Chief Innovation Officer with Houston Methodist. I'm Anthony Guerra, founder and editor-in-chief. Roberta, thanks for joining me.
Thank you so much for having me on this show.
All right, very good. Looking forward to a fun chat. Do you want to start off by telling me a little bit about your organization and your role?
Sure. Houston Methodist is now actually, as of, I guess, now or a month from now, an 8 hospital system in Houston, Texas. We have our flagship in the Texas Medical Center, and then an additional number of community hospitals, as well as a continuing care hospital. A small SNF and a small rehab are associated with the hospital. And the Center for Innovation gets the opportunity to work in each one of these environments, as well as our physician practices, where we have 160 offices and opening new ones every day, to bring new innovations to our, whether it's our ACO, our physician practices, or our hospitals.
All right, very good. Thank you for that. So the reason I reached out to you specifically was you wrote a LinkedIn post, a very nice post about what will define healthcare innovation in 2025. So off the, just in general, if you want to share some of the highlights from that post, some of the things that you wanted to touch on, some of the points you wanted to make, and then we'll go from there.
I think it's amazing to me right now to see the speed by which innovations are happening. So, one of the things that we have built, which I really do believe is kind of that wave of the future, and certainly for us, our 2025, is we have now equipped every one of our patient care rooms with cameras. And in that allows us to start the journey, which we've begun with centralization of services. And it's centralization of whether it's telepsych and telestroke, which predated this camera journey, our virtual ICU, which we opened a month before the first COVID patient arrived, but now have added on medication reconciliation. We've added on telehospitalists into the room. We just had a snow event in Houston. We turned on the cameras and had lots of different physicians that were able to camera into the room. So whether it's our physicians or our staff, we're now able to use that electronic highway to begin a stronger journey towards centralization. When we look then at other areas that were in that post, we put in cameras into every one of our operating rooms, and in those operating rooms, we now are using artificial intelligence to help efficiency and quality in the operating rooms. So we're able to actually, when that drape goes up, the videos pick up that the drape goes up and immediately text the doctors to let them know that they're going up. We're using the analytics on those and have seen anywhere from a 10 to 15% bump in our operating room cases. When we look at voice, we've put in a head-to-head with 2 different companies looking at utilization of voice in the outpatient environment and the inpatient environment, and soon to hopefully start a pilot in nursing to actually use voice over type. We think that the Gen AI capabilities in that space, as well as predictive analytics, are going to be maturing in 2025, and we'll be able to measure whether or not those technologies are useful and usable. So as I talked in the text, and I hope I'm capturing a lot of those concepts here, we have the opportunity now to mature technologies and mature platforms.
All right, very good. Let's go into some of that. So obviously the cameras issue is a big thing. How is that different? Help me understand, how is that different from, like, right now I'm on a laptop, right? And I get the camera on me. Why is it important that the cameras had to be installed as opposed to some sort of device being in the room?
That's a great question, right? So for you, if you're sitting in the position that you're in, It's no problem for you to look at a virtual doctor and say, hey, I need something. And if you want to show, you and I are of capable abilities, and if the doctor says, hey, I want to look at that hand, we can lift it up and look at the hand and turn it around and really maneuver the camera. If you're laying in a bed and you are not able to turn over or go left, go right, and a doctor wants to examine you, they could do a basic, like look at your front. But now, if we want to look at wounds or we want to look at the medications you're on, we recognize that we needed sophisticated cameras. And we had them in the ICUs, and we have learned the power of those. And we said, if we're going to do it there, we really need to wire everything and get it wired so that we can do sophisticated work. It was interesting, right? The question was, how many highways, how many cars could you drive across an iPad highway? And the answer was very few. Because the iPad, right? I'm holding it up and okay, can you hold it up? Can you lean it to the left? Can you lean it to the right? Can you see the whole person? Well, I mean, I'm looking at Anthony. I don't see all of Anthony. I see
Mm,
just his head, right? What are you going to stand up, lean back, move back, and show me the rest of your body, right? It
mhm,
it just doesn't work.
mhm.
So if we wanted to do telesitting, telemonitoring, um, tele-review of your medications, everything needed a sophisticated tech. We wanted to take picture for wound
Hmm.
care. We wanted to document for code blues. Whatever we wanted to do, it just we couldn't do it with a cart, right? We needed a one for one in the room. And that was a big decision. I mean, you're talking millions of dollars to make that decision. But now, as we go into one of our things that's going online in 2025 is what we call our smart hospital. They're moving forward with new nursing models because, again, we have those sophisticated cameras. They couldn't have
Well,
done it without that.
yeah, it's really fascinating. So it's this idea that if we put this piece of technology in place, if you want to consider a camera technology, if we put this piece of technology in place, it will allow us to do all these other things, right? It kind of empowers that, it opens up a lot of things.
Indeed. And that's the same in the operating room, right? We put the cameras in four corners of the operating room to start doing and documenting things via video rather than human. Because we have found that our humans, more than 60% of the time, were greater than 10 minutes off in their timing. And while you might think that's not a big deal, 10 minutes in an operating room, it's not that they didn't want to document accurately. They're just busy. They just, they're doing a lot of things. Can you get this drug? Can you find that piece of equipment? Can you do this? Can you do that? The last thing they're doing is basically saying, hey, I want to make sure that I exactly documented when the patient was draped and called for the doctor, right? They're doing a million things to get that patient ready, especially in cases that you're turning over every 30 minutes.
Right.
So to a certain extent, this now captures accurately, which helps you move those cases along. The byproduct of it is if you have a quality concern on, for us, we were looking at infection control during the turnover of the cases. We were immediately able to go back and look at the video of the rooms in between the cases and how well we were cleaning.
Hmm. Very interesting. Let's talk a little bit more about this, and it brings in a larger issue that I think is extremely important in healthcare, probably in every industry, but specifically in healthcare. When we talk about something like this going forward and the installation of cameras in patient rooms and ORs for the improvement of care and a whole bunch of other things, I'm always interested in the genesis of how these things get moving. And sort of the bigger backdrop on this dynamic is the idea from IT, from the CIO suite, we often hear about not wanting to get too far out in front of things, not want to be the driver, wanting to support what the business wants to do, and the business is often clinical care and health systems. So they don't want to get too out in front. They don't want to own it. They want operational teams to own it, but they want to support. That has to be balanced with the idea that at the CIO level, you shouldn't be just an order taker. You want to be bringing strategic insights and helping people understand where technology can be helpful, areas they haven't even thought about technology being helpful. So it's got to be a two-way street. And it's very interesting. I would like to know the camera idea. Is this IT saying, hey, we can put cameras in rooms and do all kinds of cool stuff? Or is it doctors reading all kinds of peer-reviewed papers and going, hey, other people have cameras in hospital rooms and we can do all this cool stuff? So how does something like this come about?
So interestingly, the cameras in the operating rooms came from two of our physicians who heard about them and saw them, brought them to us. We studied them operationally and then brought it to IT. So, I mean, if I pause for a second, right, I have to go back in history. Our Center for Innovation has been 50% IT, 50% operations right from the start. We never had a separate arm that was in a different building that pretended to build things that were not operational right from the start. So I would say that 90% of our things come from operations almost immediately from their genesis. IT then is right at the table with us to say if it makes sense, if it doesn't make sense, if it works, if it doesn't work. Putting the cameras in the room was actually, it has been a really interesting journey. No one at the moment in time that we went forward had scaled to the amount of beds we wanted to scale. Right? No one said, everyone had a nice pilots, 30 beds, 60 beds, right? They had small amounts of beds. Saying to them that we wanted them in 2,800 beds was a lot. And then you're talking about how much video or audio could go over your networks. We had to then go back and recognize that our network infrastructure was not built for an Internet of Things at the size and scale that we needed. So it has been a back and forth discussion with our IT group. What happens if it goes down? Is operations okay with a 60-minute pause in the video network? What are the implications? Do you need redundancy? What level of redundancy do you need? In the case of virtual nursing, who do a huge percentage of our admissions and discharges, if it doesn't work, okay, there's nurses at the bedside. If you're monitoring ICU patients, or this is your sitters centrally for the system, if you go down, it's not like we suddenly have 90 sitters that can run out and sit with patients at the bedside. So the back and forth discussions between what you absolutely must have, what the cost of that is, what you can live with is fascinating and has brought us, in some cases when families have issues that come up, they become dysfunctional. And in some cases, they become closer together. I would say going through this journey has brought us even closer together.
It's fascinating. Very interesting. With the cameras, uh, who who operates them? For example, are the nurses the ones that have to make sure they're positioned right? Are there adjustments that need to be made? Who deals with that? And then regarding the integration of the video, does that flow into the EHR? Is there, and then, I mean, I can't picture somebody sitting there watching hours and hours and hours of video. Are we using AI somehow to extrapolate learnings from the video?
So it's fascinating. Each use case, and this is where I say each car that you drive on our camera highway needs a different, right? I mean, it's are you going to drive a semi truck down the highway, or are you driving, a Tesla? Are you driving a self-driving vehicle? Right? Each one of them have different requests. So for example, the sitters, which again, the cameras are almost up in an up position until they turn on, at which point they point down. So there's always a question of that privacy, and there are privacy modes on the cameras. So lots of questions at the beginning on the privacy. Once you kind of get over those, and it's interesting how few people, once you get past the first kind of month, how few people actually ask any of those questions because it becomes kind of part of the way we do our business. So as you drive sitters on the highway, they're on all the time, right? There is somebody monitoring those feeds. We don't save them, but there's someone monitoring them. And the question is, can we add on the AI component to basically, when they move out of bed or they move out of position, can it alert somebody? Right now, no. That's different than our virtual nursing, where on the front end, we've now started questioning whether we can add the AI component so they can just speak with the patient and it documents. Our virtual hospitalists are testing that out right now and having it go, they have the conversation and it goes right into the computer as the documentation of the note. You can test it. When we look at our ICU, the information coming off of the machines, those are all in algorithms. And if the information that's coming off our bio buttons that does all the vital sign monitoring for the patients, those actually also go into algorithms. There are between 17 and 24 algorithms that point to which patients we should be concentrating on and focusing energy on. The cameras from the operating room all are based on artificial intelligence and document right into a teletracking device about what's happening at all times. None of that is human input. So each one's a little different. So you have to study, right? Once you add on each use case, you have to think through all the questions of how it will work and what that work will mean. But it does enable, we turned on the telehospitalists in 40 days. And I will tell you at the snow event, we turned on the cameras in 48 hours. We just loaded everybody in and said, here's a tutorial. We're sending you out the tutorial and here's how you enter the rooms on the camera. Now, it's probably only about 40 people who took us up on it, but 40 people made a lot of visits that they didn't have to come to the hospital.
Right. Excellent. Very good. When we talk about cameras, it makes me think how in cases like this, the physical world and the IT world come together when you have an actual device, and it adds certainly a big layer of complexity. And that's one of the reasons that we hear hospital at home programs can have a lot of challenges, and some of them have been shut down because especially the idea is we want to extend care. The further we extend care, the better it is for the people that need it because they're further away, but the more difficult it is to service that site, that home, that farm, whatever the case may be, because we actually physically have to, either get there or have things shipped back and forth if they're not working, not to mention bandwidth issues, that whole last mile thing, cybersecurity concerns. What are your thoughts on where hospital at home stands and overcoming, if we're going to, and then the whole payer situation and what reimbursement is another issue, but where do you think sort of care in the home stands right now?
Some of the programs have just been too small, right? And they haven't survived because they really haven't had lots of enrollment. Some of the programs are doing very well. I think there's a level in between full hospital at home and full in the hospital, right? There's what I call hospital at home light that I think in the coming years will really start to take off, which is I keep you tethered to me in one way, shape, or form in another. That's a virtual visit, that may be a sitter, that may be a device that you're wearing. I was having a conversation with my dad down here in Florida as I'm visiting him, and reminded that one of the ways that people spoke about whether or not knowing a senior is okay is if we put sensors on the refrigerator. If they get up in the morning and they go to the kitchen and they're hungry and they want to eat, they're probably okay.
No, interesting.
So what are the different devices that you can tether to an individual to get them to be okay, right? And check on them and see if they're doing all right, or if you need to bring them in and monitor them and help uh, optimize their health status while they're not with you. That's one of the reasons that we decided to scale the virtual center on the inpatient level. So we knew we could scale. We knew we could scale to lots of patients. Now adding 300 patients at home on various devices is not as big of a deal as it was when we didn't even know what we were doing. It's hard to just have 300 patients. That is a onerous cost. But if now you're doing the inpatient and just adding on the outpatients, it's a fraction of the cost.
So it's definitely something that, what would your advice be to other CIOs, IT departments around hospital at home and extending health beyond the four walls? They still need to be skating to that puck. That's not going away, right?
No, I think what we all have learned is that managing the patients that are not in our reach is more and more being laid at the feet of the hospitals, right? So the question is 30 days afterwards, how are they doing? 90 days afterwards, the total cost of care. All of those things are being pushed more and more to the hospital management, even if you don't have a value system where you own that top dollar. And because of that, because of the fact of owning that responsibility, we're having to figure out how to do that. And so that's the challenge of trying to figure out how to own those, the care, or at least the did you have to come back? Did you have to return to the hospital? Could we have kept you out if we had known better what was going on? Could we have done a better job? So that's forcing us into that territory, even if you weren't a full hospital at home, which means you're going to have to figure out how to own not only the information about what's happening with that patient, but when are their return visits? And in some cases, they're vital, right? We had, I'll take it, I don't know, a huge number of patients that in a snowstorm last week skipped their dialysis treatments because it wasn't convenient for them to go. By Jove, by this week, I'm dealing with a huge amount of deconditioned patients who skipped 1 to 2 dialysis treatments.
Mm-hmm.
Did they need to come to me? No. I should have figured out how to get them out. We also need the payment systems to figure out how to appropriately do the incentives so the cost of that is not just laid at the feet of the hospitals. So I think there's a lot of interesting implications of being able to do this, and then figuring out how we continue to do a better job of going beyond our hospital walls.
All right, very good. Let's talk a little bit about selecting the right projects to work on, the right things to work on. That's obviously governance comes into play there. But just to say we need governance, I don't, that's moderately helpful. It's what does good governance look like, right? Because I guess we can have bad governance, in which case we're doing governance, but we're really not, we don't have the structure set up to select the right projects. So a little bit of that, and also this concept of pilot fatigue. So there's that idea out there that people are trying too many things, maybe wearing out their users, because every pilot affects certain users. So picking the right things, not picking too many things, but also we know pilots have to fail sometimes or they're not pilots, right? If they all work out, they're not pilots. So there's a balance between trying too many things and not trying enough things. What are your thoughts there?
So I was listening to a good, Richard Zane was phenomenal in one of his podcasts recently, and he said, "I've given up the term pilot. We never used it. Our kind of language is we assume success, and so when we assume success of any product that we're doing, that means that it has to be scalable and affordable. right? Can we afford to scale it? Can we technologically scale it? At 8 hospitals, 2,400 beds, 160 physician practices, what is the cost and what is the return on investment that we're expecting from scalability? We then go back and say, okay, where is the starting trial for this to prove out what we are expecting? So once we do that, right, once we do the trial, then the question is, we've already contracted for a full scale. We've already assessed what it would do at full scale. We've already assessed how this, matches up to other products. We've already studied how long it will be before Epic has this in their quill, and in their suite of products, and how that's going to compare, and whether or not it's worth doing it for the amount of time that it will take, right? You've already assessed that. You've assessed the overlap. A lot of times health systems, it's like, oh, this one does A and B, the next one does B and C. Is it really worth bringing on B and C if you've got A and B, right? Is that fair, or is that smart? So that's one of the assessments that have to be done. And then the question is, how much can IT handle? And how much can operations handle? Right? Sometimes it's IT that says enough's enough, people. And sometimes it's operations that's like, you cannot bring us one more thing this year. So all of those questions have to be asked very honestly and openly, and not offensively, because people are bringing you great ideas and great products. And the last thing I would ever want to do is slow innovators who bring us fantastic things that honestly we can't imagine living without now. So I love the fact that we constantly get these amazing and incredible new ideas from people. And I feel blessed about that. I never want that to stop. But we have to, we have a great product that's come out that I had to say to a company, honestly, our IT just raised their hands and said, it may be great. We can't change and we can't do it now. It's not the right time. And I had to call this great company that we had kind of planned to do a lot of work with and say, I really want to work with you. We can't, not now. And then there's other ones that we assess and look at them and say, is it worth it? And recognize the maturity of them. They're excited, but not ready.
Wow,
And
that's yeah, a lot of good stuff there. Go ahead.
yeah, I think people are so afraid to be transparent with one another that sometimes everyone loses because they end up fighting each other rather than just saying, okay, I hear you. Like, I'm going to push you, but when you push back, it's usually valid. And I love that about our
Yes.
culture and about our people.
So there's I mean, a lot of trust has to come into play there, right? I mean, when you're told by the IT department, we're at max capacity because they're trying to protect their people from burnout, right? We're always talking about trying to protect clinicians from burnout. IT folks can get burned, anyone can get burned out. So, theoretically, the CIO, if that's, in this case, is going to say we're at max capacity and I can't, I can't have my people do any more right now. So it's an act of kindness and not an act of sort of, we don't want to work any harder. And you or whoever's bringing it to them, hopefully there's that trust there that they would do it if they could. And when you're told no, that's not something they did lightly or for fun. And everyone's got to understand each other and have respect and grace and all this kind of stuff.
Yep. And I think that is very true. If you view yourselves as, two sides of, the pancake, you don't get one without the other.
Mm-hmm.
Operations and IT have to be really well in sync to make a product launch go well.
Now, where do you think you sit? I mean, would you say you sit in IT or operations, or are you kind of straddling that like CMIOs and CNIOs?
I would say that I have 33 years in the business and 24 of them as an operator.
Okay.
So when I bring something from operations, I will have already, someone said to me very nicely, it's hard to say no to you, Roberta. And it's like, yes, because by the time I bring it to you, I've already played out the no's. So when I look at a product, and my favorite ones are the ones that, like, they ask a nurse to put it around the finger, 6 wires up the arm, down the chest, and, do whatever. I already can tell the product team, I'm not bringing that to nursing. They're just going to look at me like I got 6 heads. Like, no. And if a company basically says to me, it's okay, you'll just run this synthetic data on like a whole new server, set. And I'm like, really? Do you really think I'm going to bring that to IT? Like,
Right.
no. So I've at least asked questions 1 through 20, and I'm really good at questions 1 through 20. And then it's like, okay, now I'm going to press you, and I'm pushy enough to ask and not give up. But then when people basically explain to me why it just won't work, I'm a really good listener. But I'm not gonna allow them to just turn around and say, nope.
We're almost out of time. I just want to ask you one more question and we'll end it there. This has been a wonderful chat. You mentioned the ID before. You referenced something being in Epic's suite of products or not. One of the biggest issues that is coming up in all the interviews I'm doing is this concept of staying in suite versus going out of suite. Sort of balancing interoperability and integration of data, and maybe cost on the one side, managing cost on the one side, with perhaps innovation on the other side, though they're not totally mutually exclusive. But sometimes people want to go out of suite because they really like the niche third-party app that they've come across, and it's got all this functionality, and it's just better. But the question is, how much better and at what cost? So how are you, as someone in charge of innovation, again straddling the worlds of IT and operations, how are you handling those decisions?
They are really good and fluid questions that need to be asked almost every quarter, because the development, there are things that I see today that someone has said to me, by 2027, Epic will have surpassed the product that we have, right? All good. And there are some things that Epic is never going to tackle. We're never, okay, I shouldn't say never, because who knows? But I don't think we're going to see in the next 5 years Epic cameras hanging in the room, right? But I do think we are working right now on Epic bedside showing up through the cameras and the education happening through the cameras into the room without an infotainment system, right? We made a decision not to do infotainment because we think we could do that more directly.
Hmm.
Great. We think Epic will get there. Is it a lot of work for us to basically work through the initial stages? Could we do better in the next year with another product? Possibly. But that we actually deemed that it was coming and coming soon enough. But there are other ones where I say they're not there, or they're not going to be there in the short time. We will get a return of the investment in the next 1, 2, 3, 5 years. And so it's worth it.
Mhm.
But I think if you're not asking the questions, then, sad for you. But if you're so afraid not to do anything, not to step out on the limb, on the ledge, because Epic might do it soon, then you're missing out on some of that opportunity, whether it's customer acquisition, whether it's um, uh, uh, predictive analytics, whether it's improvements in quality. Don't skip those opportunities, but I also caution the companies to recognize where the big platforms are going, and recognize the big platforms are just going to expand. It's not just Epic, whether it's Prestini, whether it's Stryker now with their healthcare AI, where there are these larger acquisitions, they are going to have the funding to do that R&D to basically expand those platforms and go more breadth and depth. So I would say to you, there's a value to more platforms, looking at the platforms and not just Epic. So I'm learning the value of that, and the companies are getting smarter.
I have to ask one more question, then I promise I'll let you go.
We can talk all day. I'm
Yeah.
happy to.
The I come across, we work with on the sponsorship side a lot of niche vendors, and they're really concerned about this dynamic. And what do they do? Like, if you're a niche vendor that, you think of yourself as high value, and let's say you feel you're better than the Epic or Oracle Cerner module or whatever you want to call it, how do you survive? How do you get customers? And then if you get a customer, and the customer, as you said, may be saying, all right, we're going to take you on now, but we've got our eye on our platform vendor, and when they're up to speed, we'll say goodbye. How do you, one, get customers, and then how do you keep them and avoid being cast aside? It's rough.
Yeah, I would say to you that if a company is a one-trick pony, survival will be very hard.
Mhm.
They have to mature and spread in multiple areas where they are not just adding value in one particular piece. Now, they have to do that exceptionally well to get in, but then they have to grow. So let's take our operating room cameras, for example. Uh, One of the things we've said to them is, hey, you know what we need to do next? Next, you need to tell us whether the instruments on the table are correct. They said, well, there are better companies, right? They didn't say this. There are better companies. I can tell you whether or not they've got great pictures of the instruments on the table. But I already have my cameras. I already have them. They're set, they're mature with this one company. So I don't need to bring in six other companies. So either I need them to acquire, right, or develop the appropriate instrumentation in the room. I need them to not be a one trick pony of getting the data from the camera into my record. And they are doing that. They are smartly maturing piece by piece. Other companies are smart enough when they're a one trick pony to basically fold into a larger platform. But keeping a niche company going in one area and one small piece of the puzzle, that's going to be very hard in a future world.
Right. So when and I'm saying, if I'm you and I'm speaking to this niche vendor, if I'm asking you about this other functionality and you're simply referring me to another company, and that's the end of it, then you're not in a very good place. You need to be thinking about bringing that in-house. I'm telling you I need that additional functionality. I don't want to go to another company. I want you to figure it out, and then you become more valuable. If you're just telling me, handing me a phone number, you're in a bad spot.
Correct.
Okay. Yep. Roberta, amazing, amazing chat today. I've thoroughly enjoyed this, and I hope you've enjoyed your walk. And this has been wonderful.
Thank you for coming on the stroll with me and bearing with me in my alternate location today. Unexpected, but it's a welcome, beautiful day out here, and it has been an absolute pleasure talking to you, Anthony.
Well, thank you, Roberta. I hope we can catch up again down the road. You have a wonderful day.
You take care.